for most of these patients, their entire education is coming from, at least medical education is coming from what they see on the internet and social media. And I think they have to get the appropriate word out there, and kind of counter that misinformation. And I think I see that patients are really appreciative when they see a good reel, when they see valuable information, they really appreciate it.
I still want to know, are we supposed to take those glasses seriously?
These are my no, they're regular glasses. I think it's
He
just the
looks
glare.
he looks very intellectual. I love it.
But
I
I
can't
mean,
see.
hold on. I
Are
gotta
they
take my
real?
casework off. And
They're real. They're
There's a
progressives.
prescription.
they look ridiculous. What?
What do you mean? They're glasses. Well, that sultry voice is the voice of Dr. Suraj Saggar. I am Clinton, Dr. Clinton Coleman. I forgot I'm a doctor sometimes. Welcome back to Recommend a Daily Dose. Excuse the absence. I think Dr. Saggar was were you away or getting some cosmetic surgery
I
or
was
something?
the ball boy for the India World Cup cricket team, so I was traveling around,
There you
making
go.
tea and waxing balls. Yeah, I was away for a little bit. And it looks like you were
That's
away. You haven't gotten a haircut in a while, so it looks like you might have been
I
away
know.
for a
I'm
while.
scheduled tomorrow, so I was saying,
there you
our amazing guest today. I'm usually not a fan of cardiologists, but he is,
Uh-oh.
he's close to near and dear to my heart. He's a good guy. He's probably the second coolest guy in the hospital. So,
That's
I thought
fair.
I was
That's
cool, but
reasonable.
this guy is like he doesn't even walk; he just floats while he's walking down the hall. So,
He floats.
Thank you for noticing. I appreciate that.
Dr. David Wow is a board certified cardiologist and director of echocardiography and cardiac rehab at Holy Name Hospital. Welcome, sir. How are you?
Thank you very much. I'm good. Thanks so much for having me. I've been looking forward to being on this program.
Well, Dave,
How are you
you
guys
definitely,
doing?
you're definitely the IQ of this program has gone up with you being here. So we appreciate you
Ah,
stopping
thank you,
by.
thank you. I
And
appreciate that.
I feel there's a lot we could ask you, a lot we could talk about, but as we always do, ask our guests, tell us a little bit about yourself, what got you into medicine, where you shop for clothes, whatever it might be, whatever you want to talk.
So I'm a non-invasive cardiologist at Holy Name. I'm in a group practice of 5 people. I guess my journey to medicine was probably no different than any of yours. It was straightforward, but a little bit interesting. My journey started in high school when I was, I think, probably 17. I was a senior and I was having some chest pain after a basketball game, probably just muscular, but the school panicked and right away sent me to see the pediatrician. And he heard all of a sudden he heard a murmur, which apparently he never heard before, sent me to cardiologist that same day. Back then, he didn't require pre-authorization. So right away, I was in the echo lab getting an echo. It was at that moment where I saw my heart beating on the echo screen, seeing my valves opening and closing, seeing the heart pumping away, seeing the blood flowing.
It's
Then I knew
cool.
right then and there I wanted to be a cardiologist. At the time, the only question for me was, did I want to be a cardiologist or a cardiac surgeon? And that was pretty much answered for me the first day of my surgical rotation. I'm sure you guys went through the same thing. You remember how
Yeah,
brutal
sure.
surgery was torture. You have the interns kind of scudding you out and but my first day, I somehow got assigned to a vascular surgery. I think it was a
Are you saying
fempop
you didn't like
bypass.
holding a retractor for 8 hours and not
Oh
being
my
able to
God,
urinate?
torture.
Waking up
So,
at
and that
four
was
in the morning to
literally what it
round.
was. I
Uh,
spent 8 to 8 hours in a fempop bypass holding a retractor.
yeah.
My legs were killing me. My back was killing me. I had to pee. I was starving. And I finally was so fed up at the end that I literally contaminated myself on purpose because you know that there's always that nasty scrub nurse looking to throw a med
Throw
student
you
out
right
of
out. Yeah.
more. And she did. And thankfully, the surgeon was nice enough to just say, go home and I'll see you 5 o'clock in the morning for pre-rounds. So at least I got home and was able to have some dinner and relax a little bit. But I knew then and there I just wanted to do general cardiology or at least cardiology. And later on during fellowship, I decided to focus on cardiac imaging
Mhm.
and general cardiology.
So, you said imaging. I'll start off first. And usually Clinton and I just kind of fire questions off. But all right, so I'm going to ask something that's a little personal. Cardiology, we see the biggest amount of cardiovascular disease genetically in the Southeast Asian population. And I wonder if you could touch upon that. Obviously, such a large population, so it's just going to add to the global metabolic disease problem, or I guess just burden, you can say. But there are and then where I'm going with this is that I know there's some issues specific within our own population, me being one of them, with like smaller coronary arteries. And then how does imaging help, i.e., some of the new modalities that may or may not be
Yes.
covered by insurance?
No, that's a great question. That's actually what I focus on. I do a lot of preventive cardiology. I believe in early detection of coronary disease and prevention. So I'm a big fan of calcium scores and
Mm.
cardiac CT. So calcium score is basically a non-contrast CAT scan of the heart to look for a calcified plaque buildup. And it's the best predictor of cardiac risk. It's
Mm.
actually considered a negative risk. If your score is zero, you're actually it takes away a point
Takes
in
us
terms
right.
of your risk for heart disease. So I very firmly believe it should be a part of screening. We should be offering it more widely. I use it mostly in high risk patients with borderline to high cholesterol if they're otherwise at risk, and we're kind of teetering on whether to treat them with a cholesterol medication.
Sure.
If they have identifiable plaque buildup, especially if the score is over 100, there's proven benefit to being on a cholesterol medication, one of the statins, to lower your cardiac risk. So it can definitely help reclassify a patient's risk because right now we mostly rely on ACC AHA risk scores, right, which is diabetes, high blood pressure, smoking,
Mm.
cholesterol, gender, age, things like that. But that misses the boat in a lot of situations. And if we can reclassify somebody because they have a high calcium score that wouldn't otherwise get a statin,
Otherwise,
we
get
can
right.
definitely reduce their risk going forward. Or we can reclassify somebody that we would otherwise perhaps put on a statin. Now, all of a sudden, say their calcium score is zero, they're lower risk. We can hold off on a statin for now. So it helps us reclassiclassify the risk score.
Who's
Any
the
So
age
best
I'm a big
person
fan.
recommend?
to?
Because go
Oh,
ahead, Clinton.
sorry.
I'll ask you. Go
I
ahead.
was gonna say because I see a lot of patients in the office and young patients, and
Mm.
they always inquire about their cardiac risk. So, we were always taught to take a family history and whatever risk factors they have. But I think has that changed? Are we doing way more imaging than we normally would do, as opposed to just taking a history and saying you're low risk for heart disease, you don't need a stress test.
Right. So I think the history is great, but there's so much we don't that only kind of predicts 50% of the risk, right? The,
Right.
the traditional risk factors only predict 50% of the risk of heart disease. So when you add cardiac imaging to it to identify early plaque buildup and minimize that risk, it really helps kind of risk stratify the patient. So
Right.
we are using more of it. I'm even seeing more internists now using it. I don't know that they're using it so appropriately.
Mm.
Right.
Um, there's,
Because
there it should be used in the appropriate patient where it's going to change management, meaning
right.
if they're already on a cholesterol medication, it doesn't really help you much. It's really the best way to use it is to identify which patients should be on a cholesterol medication earlier on, or maybe even on aspirin. Because if their score is really high, then in that situation, the risk is very high and you may add additionally aspirin to it. So you want to do it in the right patient where it's going to change management. I'm seeing a lot of people, I'm getting a lot of referrals recently for patients that have calcium scores that are very high in like a 70, 75-year-old population. You shouldn't really be using it on those patients because those patients are already traditionally pretty high risk
Oh yeah.
and
Right. So
it's
it won't
normal to
change
have
your
plaque
management. You
buildup.
already know you're going to be aggressive
It's
with it.
not going to change their management. They're already, it's normal part of aging to have plaque buildup at that age.
So
So you
because
just
what
said
I
the magic
find,
word aspirin.
can I just
I
ask a
I
follow-up
gotta
question?
interject. You said aspirin.
Okay.
Can you go a little bit over that? I know they've changed a little bit now about primary versus secondary prophylaxis with aspirin, and as you get older, over 60, the risks of bleeding.
Right. So
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 I always
definitely
tell Clenton just take an apple. He takes an aspirin sometimes a day. Should he be taking an aspirin?
used to be right, an apple and an aspirin. But yeah, they've cut back on the recommendation. Unless you're very high risk, there's not a proven benefit to being on aspirin for primary prevention,
Right.
meaning preventing that first heart attack or stroke. It's very useful for secondary prevention. If you've had a heart attack, stroke, or a stent in the heart, it's very helpful to prevent that second episode. In terms of primary prevention, the way I use it, if they have multiple risk factors, especially diabetes and a family history of heart disease,
Right.
and or if they have a plaque identifiable on a CAT scan, like if their score is above 100, then they definitely would benefit. There is data to suggest if you're younger than 60, they would benefit from being on an aspirin as well for primary prevention.
But you
And
have
if
to
their
have
risk
pretty
score,
significant disease risk factors, I guess, especially
you have
over
to have a
60, then
significant
the
risk.
risk of
Otherwise,
bleeding.
yeah, otherwise the benefit may not outweigh the risk of being on aspirin
Gotcha.
because, as you know, it can cause kidney issues, it can cause bleeding and things like that.
What about the screening? Yeah, cardiology, tends to be fad-ish. Like, there's always some new test, whether it's a genetic testing or the lipid profiles
Faddish. Oh my
or,
goodness.
huh?
Did you say faddish?
Faddish.
Like
I made
fad.
that up.
Yeah, like cool. Cool,
So
cool.
when I practice internal medicine, it's hard to know like,
Mhm.
what the best screening tool is for this type of patient. Most patients without risk factors, their heart is important to them. They want some kind of screening test. So,
No,
whether they
100%.
want these all these lipid
That's a great.
profile testing, I get confused sometimes knowing what to do. And then now
No, you're
patients are
right.
requesting calcium scores, and I like, are they appropriate? It's hard to navigate sometimes.
No, that's a great question. And there are when you look at the tests that we can use to assess somebody's risk, you think about a calcium score,
Right.
high sensitivity CRP, advanced lipid testing, and carotid interval thickening. Those are the four main things you can use to assess somebody's cardiac risk, besides, in addition to a standard lipid panel. Nothing has proven more effective than the calcium score. It is the best assessment of cardiac risk.
Mm.
Um, I have had patients come in with a high CRP level and a high cholesterol, and sometimes I've used that to push me over the edge in terms of whether to put them on a statin. But if we're not sure, then I would do the calcium score. The calcium score is by far the best at assessing cardiac risk. It's better than the advanced. I don't use advanced lipids a lot, to be honest.
So advanced lipids, you mean like lipoprotein A, those type of things?
Like LP little a, alpha protein B,
Like the Berkeley
the
test.
the particle size, things like that. I think there's some data behind it. There's not a lot of
Sure.
data in terms of whether you intervene and reduce those numbers, whether there's a proven benefit to it. So it does predict cardiac risk, but we don't have a lot of proof that if you intervene based on that, that it minimizes risk. There is good data based on a calcium score that if their score is above 100, then they definitely would benefit from a cholesterol lowering medication like a statin. And between 0 and 100, meaning you have any identifiable plaque and you have risk factors, there's also probably a benefit to being on a statin.
So of course I have to ask, this cardiac CT covered by insurance?
So it depends on the insurance. Calcium score is typically not, but most
Mm.
places offer it for about $100 out of pocket. So I think pretty affordable.
Yeah.
A cardiac CT, which you would generally, a cardiac CT is more advanced. You get better resolution. You can actually look for narrowing the same views as you get on an invasive angiogram. A cardiac CT will be managed, it will be covered now, especially in patients that are symptomatic if they're at least intermediate risk.
How
So
about
we're getting better
asymptomatic
coverage
with
of cardiac
someone's
CT
strong
now.
family history, and then let's say you're a middle-aged African American gentleman, and you're trying to pick up your jazzercise and other things that you do in your free time. Like, would that be
What's middle age, by the
approved?
way?
Is
So
that,
you're middle-aged,
I was
Is
gonna
middle
say, is
age
that
younger
is
than
that
you?
jazzercise personal experience? Is that what you use?
Well, I mean, Clinton, you want to talk about it? I mean, I think
I'm not
I
middle
may have cleared
age.
him medically so he could do the water aerobics and jazzercise.
That's
And
actually a good question.
sleepwalking if he doesn't.
The NBA draft just was this week. Bronny James was selected, I think
Oh
55.
my God.
So
So,
first father-son
Wow.
duo in the NBA? Is that for
but
real?
Such
mostly
nepotism.
about like, are there any different recommendations for cardiac screening, like for structural issues with young athletes?
Hmm.
Growing up, we
I,
just did a physical that, they listened to for a murmur, but
I
it's
I
pretty
think they're just
scary.
recommending EKGs for competitive athletes right now, which I
Okay.
think misses the boat.
That would
Um,
have caught his, probably not, right? I think he had with BT or,
he beat the, but he only would have caught it if he had it at the time or if his
yeah.
QT was prolonged. So an EKG can pick up QT prolongation, and it
Yes.
should show signs if there is HCM, hypertrophic cardiomyopathy, but it
Mhm.
doesn't in 100% of the cases. So it's a reasonable starting tool, but I think if you're a really competitive athlete, if there's other signs like a heart murmur, then definitely we need an echocardiogram. But there's not enough data right now to suggest echocardiograms on every
On
competitive athlete in
all
the country.
young
That would not be
athletes.
cost effective.
All right, so I think we should switch gears a little bit. I
Sure.
mean, you may have noticed that Clinton has lost some weight recently, looking a little thinner, and a
Looking
little
good. Looking good,
My
Clinton.
hair is thinning.
Um, so
Oh, welcome to the club on that
we
one.
have to bring it up there for our listeners, for ourselves, for Clinton especially, as he is getting ready for bathing suit season. Like, can you touch upon, actually in great detail, the use of Ozempic and these other Manjaro and these other drugs that
Yeah. So
basically
this
anyone and
is
everyone is going to ask every
so
physician.
yeah. So first I'm going to say in terms of social media and weight loss medication, it's probably the most polarizing topic on social media that I see besides
Mhm.
statins. Um, so I may have an unpopular opinion. I believe we should be using more GLP medication, the weight loss medication like Ozempic, Wegovy, Mounjaro,
Mm.
in the appropriate patient. So I say appropriate patient because I'm not referring to the person that's 10 or 15 pounds overweight that just wants to fit into their prom dress, wedding dress, or skinny jeans. So, I'm talking about the 350-pound 40-year-old patient that has
Sure.
prediabetes or diabetes, has the beginnings of arthritis in their knees or hip and family history and is high risk, basically is a setup for a walking heart attack.
Sure.
Like in that patient, and if they've exhausted all other options in terms of a structured, heart healthy diet, along with a fitness program, then I think it's perfectly appropriate to consider GLP medication to reduce weight and further reduce their cardiac risk. I think that there is right now, there is such a stigma attached to the weight loss medication. I even did a poll recently on my social media to ask if people consider it cheating. And about 60% say they think it's appropriate, and about 40% said that they consider it cheating, quote unquote. And
Hmm.
it's a pretty almost even split. And I think it's unfair to label patients as cheaters because they're using the GLP medications, right?
Sure.
They, the appearance is that patients that are overweight, it's only because of a lifestyle choice. And I think that's fair for maybe somebody's 10 or 15 pounds of weight. Listen, I have my ups and downs. You've seen me over the years. Like I sometimes will let myself go a little bit in terms of diet. I may gain 5 or 10 pounds. But for somebody that's 350, 400, 600 pounds, that's not a lifestyle choice. There's so many other factors that go into
Point.
Right.
Yeah.
what determines your weight and obesity, right? There's your gender, there's ethnicity, there's hormone imbalances, your genetics, most importantly, and things like that. And rather than shaming or embarrassing these patients for and stigmatizing them for making the choice beyond a weight loss medication, I think we should be praising them for making the brave decision to ask for help when they need it. So that's my stance on it. I think there's an unfair criticism for patients that are on the weight loss medication. I do think we, in certain situations, we're certainly overusing it, and I think it should be covered better on their insurance plans. Right now, insurance plans are cutting back on it on coverage.
Well, basically, because I mean, it's once you're on it for life, as far as we know. In fact, I forgot which pharma company. It's one of the Northern European countries, but the GDP of the entire country went up by like 2%. So astronomical number
Right.
because
So
of the amount of drug being sold.
right. So I think if it redistribute who you're using it with, because right now it is being used inappropriately on a lot of patients, right? It's
Right.
being used in a lot of patients that are only 10 or 15 pounds of weight. Those patients should not be on a GLP. But a patient like a diabetic that's 400 pounds, it's fair to put them on that because if you compare the the financial burden if they develop heart attacks and other things down the
Of
road,
course.
I would
Yeah.
imagine we probably spend less on the GLP medication. That has to be studied further. I don't know the exact data on that, but the longer you're on it, the more effective it is in terms of maintaining the weight loss. If you take it for a full 4 or 5 years, even if you stop it, there's a good chance you can sustain that weight loss indefinitely. And I guess the idea is if you can get down to a fairly normal weight and work on your exercise and other regimen, if you come off it, you might be able to hopefully sustain that weight loss
Because then
or
becomes just
sustain
part of
that
your new
weight.
norm. But I guess
Yeah.
maybe we have to say that it's not without its side effects, right? Maybe you can touch upon those. I know
Right.
Clinton
So
has some GI symptoms sometimes, or you want to talk about
right.
those?
So I think the side effects are overstated. The most
Hmm.
common side effects are, like you mentioned, GI side effects. So nausea, feeling gassy, belching, things like that. That's the most common reason that people stop it. There are cases of pancreatitis. Of all the patients, I have never seen and gastroparesis, which is when what the gastroparesis is, but when the stomach is paralyzed, I've never seen any of those major side effects in any of the patients I've had.
Right.
I prescribed it. I mean, I probably have 15 or 20 at least now on it in my own practice, and more that have come into my practice on it. And the most common side effects are just feeling nauseated, feeling full, feeling gassy. And that's how the medication works. It slows down your, transit through your GI system. So it's going to make you feel full and it reduces your appetite. But I haven't seen any of the major side effects in any of my
Yeah, I use it
patients,
a
to be
lot
honest.
in my practice and no major side effects. But I think
Yeah,
once you get past the cosmetic issues with it, the health benefits are huge, right? As far as
they're
cardiac,
huge.
kidney disease, high blood
Yeah.
pressure, the whole metabolic syndrome.
And
So,
even for addiction now, they're looking at it for
yep,
alcohol abuse and other things. So
yeah.
this
Hmm.
it all affects the reward center in the brain. So it's going to help with a lot of those things.
So how do you
So I
deal
think
with,
it's a
I mean,
really
you're on social media a lot. How do you deal with the education, misinformation? So
it's huge.
there's
Are
people on
people
the good
sending you hate mail?
side.
Who's asking?
There's doctors who are, we call them like quacks, a little crazy, but they use their
Yeah,
MDDO as, a title and they spout all kinds of weird stuff. And then there's
forget the
people
time. I
on the
mean,
right side. It's so hard sometimes.
so I've seen it from both sides. I've seen it from the physician side of it in terms of patient care, and I've seen it from I wouldn't call myself a content creator or anything like that, but I've dabbled in social media. So I guess let me touch from the physician perspective. And I'll use the example of statin medication. So for whatever the reason, the statins, the cholesterol lowering medications get such a bad rap online and on social media.
Hmm.
And you already have a hill to climb when it comes to convincing cardiac patients to take medications because they're already on 5 or 6 medications for heart failure, coronary disease, high blood pressure. Now you're trying to convince them to take another medication. And they're coming into the office already with this preconceived misconception that the cholesterol medication statins are dangerous and they're gonna die from them. And that's because of what they're seeing online. So I remind patients that the decisions that we make are all based on evidence. It's all evidence-based, right? We rely on peer-reviewed, double-blinded, placebo-controlled studies, right? But anybody can write whatever they want online based on their experience. So you have
Right.
one person, whether it's a fake, degree or just a normal patient that took a statin medication and got a toe had toe pain, and right away they'll say, "Oh, I had muscle aches from the statin medication. Don't take it; it's going to kill you." And people listen to it, and they come in and basically say, "I'm never taking a statin medication." So it really creates an obstacle to appropriate patient care, and it's a conversation that you really have to have with patients to be careful. And I'm very open with them, especially when it comes to statins. I tell them, don't read about it, don't Google it, and don't look on social media. I'll tell you if there's anything you need to worry about because the muscle aches and other side effects are so overstated. In reality, very few
Yeah.
patients really experience those symptoms, and very few patients are really limited by them. And then from the other side of it, those same in terms of putting up posts about cholesterol or weight loss medications, those same people that are putting up those posts about, oh, don't take statins, those are the first people that'll really rip your posts, right? They become like real trolls. So I always tell people you have to have very thick skin if you're going to be in the social media world.
Right.
And they'll come on, they will rip you. They'll be like, and these guys don't really have a background, so they have a fake degree, whatever it is. They call themselves a doctor, and they will say, "Oh, don't list this clown," or "Where did he go to medical school?" or "Does he really have a degree?" Simply by putting
Or
something
I
up.
find a lot of times they'll say, "Oh, this doctor, that doctor," they're just in the pockets of the pharma companies, right?
Yeah.
And
Yeah, I
they
see that a
somehow
lot.
assume that every doctor is lining their pockets with proceeds, and
Right.
this is why we're recommending
There's a lot
not
of
to.
there's a lot of assumptions out there, and listen, I don't engage. I ignore it. You just have to educate, and I think the best way for us to handle that aspect of misinformation is by countering with we should be putting up posts. That's part of why I got into it because I can only influence 20 or 25 pages a day, the people I see in the office.
Right.
But if I can expand my scope of
Audience.
practice to beyond and to other people, right now I have maybe 8,500 followers, whatever it is, and that's a small amount compared to other people. But if they're all seeing that, if I can counter whatever misinformation is out there with
Right.
appropriate information about what high blood pressure is, when you should be on medication, how to quit smoking, that the weight loss medications are safe and helpful in the right patient, then we might be doing some good in influencing some of these patients.
I think you're definitely doing good. That's why we need physicians to engage. I mean, my opinion in social media. That's why I do the news. Same idea. You could talk to 25, 30 patients max a day. But if someone hears you saying something and they take even 10% of it from, like you said, evidence-based medicine that is counteracting. Because during the pandemic, we often said there's a pandemic misinformation. We all know that. And, now you mentioned COVID, it's very toxic, just like politics. It's very polarizing. But I think that's why you need more physicians out there.
Right. So it's
Because we know a large percent of the population engage they're not reading journals. They may want 30-second soundbite, and that's fine.
they're right. They're for most of these patients, their entire education is coming from, at least medical education is coming from what they see on the internet and social media. And I think we have to get the appropriate word out there, and kind of counter that misinformation. And I think I see that patients are really appreciative
Right.
when they see a good reel, when they see valuable information, they really appreciate it.
Yeah, I think historically we've always relied on these physician groups like American Heart Association, you know, Cancer Society, whatever society, to actually put out the proper message. I don't know if they have as much impact as
I
they've
think a lot of
shown
them
in
are
the
a little bit slow
past.
to the game, right? They've been slow. You can have academic medicine, and in the academic world, it's very dignified, and they're talking about studies, et cetera. But the general population, it may not trickle down. It may trickle down to the physicians in the community, but it doesn't necessarily translate well to the Joe public understanding.
Right, 100%. You need to
How to,
you need to lay
small, easily digestible bits of information.
Is that
100%.
a
You need to
failure
you
on our
need to lay it
part
out.
though, or
What do you say?
is that a failure on our part though? Like
I think it used
I
to,
think
in my opinion, I think it used to be that physicians were kind of like, this is the old days, talking down the patient. Now, I think the idea is you have to talk to them, not at them. And
100%.
the reality is that how people digest information, politics, sport, anything, news, health information, fitness,
Yeah.
whatever, is through small
What,
digestible bites on social media.
yeah,
Well,
what
the
I see on
CDC
social
doesn't get
media
that
is
memo then, I guess.
No, I don't think so. They're definitely
no.
behind.
And I see a lot of patients, a lot of questions I get were patients that felt kind of unfulfilled by their encounter with their own physician, that they felt like their physician either ignored their symptoms, ignored their
Right.
complaints, or didn't explain it well. And I think you really have to explain it in layperson's terms. You really
Right.
have to say it in like you said, small sound bites and on their level. And it's not to take away from the patients, but it's not too many times we speak and on our own level with with the education and experience that we've had for 15, 20 years. And also even when you're doing it in social media, you want to make it very precise. Like, somebody that helped me that mentored me at the beginning said, you don't want to do those 90-second reels. You want to keep it 45 seconds or less for the most part because people's attention spans are very small, right? So me too. I don't watch it. If you don't grab me in the first 5, 10 seconds of a reel, I'm done. So you have to grab it, little small sound bites, and to keep people interested.
I agree. I mean, I don't know if you noticed, that's why I always talk first to make sure that we get the audience in, because otherwise Clinton with his, Billy Ray voice just kind of puts everyone, was
I
it
run the
Billy D.
engagement.
Williams? Is that what it just
Billy
puts
D.
everyone at
Williams.
ease, but they just kind of just fade out. They're so calm.
I
They
think
just
he's got a great
listen.
voice. It's very
It may
soothing.
not. Oh,
Thank you.
I want to go speed round here because I still have, I'm being selfish, but I have still some cardiac questions. Fish oil, should we be taking it, not taking it? Is it, I feel like it's the pendulum
So
keeps
here's
going back
my
and forth.
yeah, here's my spiel on fish oil. I think if you don't eat any fish, I think it's reasonable to take fish oil. Or the only proven benefit of fish oil really in studies is to lower triglycerides. So if your
Right.
triglycerides are 250 or above, and you've tried with a heart healthy diet and you still can't bring it down, there is some proven benefit to taking additional fish oil. So really, I reserve it for high triglycerides. Otherwise, I tell patients if you eat fish a few times a week, you should be good.
Yeah.
If you don't eat any fish, it probably can't hurt to take fish oil.
So, and how about vitamin D? I mean, they kept on telling us we should be screening for vitamin D and then supplementing, and they were lowering the threshold, protective for cardiac health, right? But now there seems to be some back and forth whether we should be or not supplementing with vitamin D.
Right. So I think we need to it needs to be looked more closely. I don't think there's enough data to say yes or no on the vitamin D
Hmm.
right now. It needs to be looked at more closely. It needs to be bigger studies.
All right, so this is fascinating stuff, and of course I'm putting a lot of personal questions out there because the
No,
reality
no.
is, we talked about it, the South Indian community, and I don't, okay, is this true or not? And I don't, you may not know the question, I don't know either, but we call it in our family the Saggar family curse, where you start losing your hair, but you get it on your ears. And someone told me the genetic allele for both cardiovascular disease and hair on the ears. So now I go to the barbershop, the guy's like just spending more time on my ear than on my head, which is all odd. And that's maybe
Wow.
a discussion for a different day. We all can't have the Jerry curl. Was it the Soul Glow look
So
that
glow.
Dr. Coleman is sporting today? But all kidding aside, you know, do you, this is what I wanted to talk about. Is it worth treating or being more aggressive with certain patients? There's some people tell me for cardiovascular disease, if you look at lipid panel for a Caucasian versus Southeast Asian, that you can't just apples to apples. You have to be much more aggressive. And our cardiologists starting to do that, where they look at different ethnic groups and knowing different genetic makeups and maybe differences from a cardiovascular point of view.
Yeah, I think
Is there a role in in treating people differently based on genetic known genetic risk factors or
right,
racial
genetic risk
or
factors,
ethnic or even ethnic
ethnic. Yeah, so definitely in terms of ethnicity, I think there are definitely certain times where you'd be more aggressive in whatever the ethnic group is. Southeast Asians might have more aggressive coronary disease, so I might have a lower threshold than if I'm treating a Caucasian.
Hmm,
But you have to look at the entire picture, what all the risk factors are. But ethnicity is a big one. Family history, nothing's been proven more than having plaque buildup, so where
right.
the calcium score comes in, and high cholesterol and family history. Those are the most important risk factors. But yeah, ethnicity definitely could play a role in terms of pushing me to be more aggressive in lipid lowering.
What are your thoughts on these crazy diets that are like extremes of one another? So it's you could be the all meat diet or the vegan
Oh my
diet. Is there
God,
a middle
the
ground
carnivore diet.
or
So So
Hmm.
I am not in favor of any what we call elimination diets. Anything where you completely eliminate anything. I think the best diet in general is a well-balanced diet. I mean, we have to remember that we're omnivores. We're meant to be eating from all the food groups. That's the healthiest diet. You can't sustain yourself in the long term by eliminating completely any food group, whether it's sugar, protein, or whatever. And I think people have to be very careful where they're getting their information from. So the carnivore diet, there is no proven data long term. I know there's some short term data showing that there's beneficial um, biomarker um, profiles in patients that are short term on a carnivore diet. But
Right.
I can tell you from firsthand experience, every patient I've seen with a carnivore diet comes in with a cholesterol panel with their total cholesterol in the 300s and their LDL above 200. And we know that that's a major risk factor for heart disease.
Right.
So but patients or a person may say, well, I didn't have a massive heart attack while on the carnivore diet. And I felt really good. So then they tell everybody else that they should be on the carnivore diet. So for me,
Not yet.
you have to be really careful. This is again where patients have to be careful where they're getting their information from. I think the best diet in general is a well-balanced portion control diet with foods from all the groups. I think you have to be careful. I think short term, those elimination diets might be effective, but long term, they're not sustainable.
I feel like the Mediterranean diet always comes back as the classic,
Mediterranean diet is a great diet.
right? It
Yeah.
always seems to be people go on the South Beach diet, whatever diet. We actually had someone that was a proponent of the carnivore diet, and as someone who's a pescatarian, when our guest started talking about drinking meat juice, I
Mhm.
almost had to leave
Oh my God.
the podcast.
I almost heave when they tell me what they're eating. It's
Right, right.
insane.
But I feel like
It's
the pendulum
crazy.
keeps switching back and forth, but it always comes back. And what's never out of vogue, what always seems to make sense is the Mediterranean diet, which, like you said, is a little bit of everything, and certainly maybe less protein and more fish, and are more
Right.
and then more
It's
well
right. It leans
balanced.
more heavily on fish for the source of protein than
Correct,
meats.
right.
And I think that should be the
And
core.
smaller, even smaller portion sizes,
Right.
etc.
And exactly.
Yeah,
Yep.
it's
I
excellent.
think a Mediterranean diet is a great example for patients. And I always tell patients if they're really having trouble and either see a dietitian, nutritionist, or stick with one of the structured diets, like Weight Watchers and Noom are very good structured diets where it's teaching
Mm.
you just a balanced
Hmm.
diet and eating from the healthier food groups, things like that. So if you're having trouble, the structured diets are very helpful for you,
I
for your
agree,
patients.
but interesting enough, I think Weight Watchers financially was in some trouble since Ozempic. I think even Oprah kind of left the ship there.
Yeah.
So we'll see how that goes. Dave, this has been absolutely fascinating. And, we kind of just hit you with a lot of information at once. Tell us a little
No,
bit
thank you.
about where any of our listeners can find you on social media, your handles, etc.
So I'm at David Wild MD on Instagram, and then I'm also on TikTok. I believe it's the Heart Doc. Those are
TikTok.
my two main.
You're not
Yeah,
doing
the Heart Doc.
dances, are you? All right.
What is that?
No dances though, right? Just
No, Dan. I
information.
haven't gotten to dances yet. You trust me, you don't want to see me dance.
Ah, ah.
It's not pretty. But one of these
And then
days.
your office, where's your office? And if people want to reach out to you, doing a lot of
So
preventive cardiology.
yeah, so I do a lot of random cardiology. So if you ever want to see me, we have two offices, one in Teaneck, New Jersey on Teaneck Road, and then we have another one in Edgewater on River Road. Always happy. And then people can also shoot me messages on Instagram or TikTok. I'm happy to answer.
Awesome.
Well, we are very lucky this fine Monday afternoon to have Dr. David Wild, who is not only our colleague but also our friend, join us
Thank
today.
you. I appreciate that,
No,
guys.
no, we appreciate your expertise and also your enthusiasm because, like you said, you put yourself out there, or any of us put ourselves out there, and we're putting content with the hope and intent to educate. And we know
Absolutely.
that you're by doing that, there are going to be people out there who may not understand what you're trying to do or trying to do counterproductive things, but you have to just look past it because in the end of the day, patients and the general public appreciate it as we appreciate you. So please come back again.
Thank you. And I appreciate you guys. Thanks for having me on. I think you guys are doing a great job and I enjoy watching your podcast.
No, thanks, man. So until next time, Dr. Stuart Slugger, Dr. Clinton Coleman, any parting words here, Clinton?
Thank you.
No, I just said I meant when I said you're one of the good cardiologists. We cardiology
Thank you.
and nephrology butt heads so
Right.
much.
We're always butting heads. It's, dehydration,
Fluids or no
cardiorenal.
fluids? Too much fluids,
You're
too
easy
Right.
to
little
work
fluids.
with.
Exactly. But you're a good nephrologist, good renal. I trust your opinion on most. We don't butt heads too much, you and I,
No,
when it comes to
we're on the same
patients.
And
We
see,
page.
ID
usually
gets
agree.
along with everybody because we treat across the.
ID is just looking up in the book what
Just
antibiotic to
procalcitonin,
give. There's nothing
procalcitonin.
really
That's
to.
all you need.
All right, that I'll address that issue another day. Until next time, Dr. Suraj Saggar, Dr. Clinton Coleman, your co-host. Please don't forget to listen, rate, and subscribe. Until next time, be well.